For patients who have multiple myeloma that has relapsed and are elderly, the challenges certainly are more marked than often those that we have to treat patients who are otherwise in good health. The choice of regimen has to be tailored to the frailty of the patient. One of the things that we are realizing in patients that are older, that a proper geriatric assessment is often important, and that just cursory assessments like performance status using the KPS scale or the ECOG scale are not sufficient sometimes to get a true sense for what patients can or cannot tolerate. In regard to patients who are having comorbidities and frailty, we need to be sure that we reduce the dose of agents that we use conventionally in patients who are younger and healthier. They often cannot tolerate the full doses of the drugs. Also, we need to tailor our treatments. Not every patient, honestly, who is older and frailer will often tolerate a 3-drug regimen. So in some patients, we do have to go back to using 2-drug regimens to balance the toxicity with the efficacy. In older patients, we are often willing to give up some efficacy for better tolerability. The older patients are the ones that often will require drugs to be given serially rather than concurrently. So we know that the older patients do have a more challenging situation to overcome often compared to the younger population that we treat. We are fortunate in multiple myeloma that we have had a good 2 decades, that we have had several new classes of drugs that have become available to patients that were not available in the past. What is even more exciting is that we have certainly not finished with the discoveries in multiple myeloma. There are a lot of new compounds that are in clinical trials that are looking promising. The BCMA-directed therapies, B-cell maturation antigen, is a molecule present mainly on plasma cells, so offers the chance for developing targeted therapies. The BCMA antigen has been targeted using CAR T cells, which have certainly been the subject of great excitement and results unparalleled to any other modality in such a refractory population. But also BCMA is being targeted using other strategies like antibody drug conjugates, bispecific molecules, and these offer often more ready off-the-shelf access for patients. Patients also should look forward to the approval of other new classes of drugs in multiple myeloma. Venetoclax, a drug that is already marketed for some leukemias and lymphoma, seems to be active in multiple myeloma, especially patients who have a translocation involving 1114. There are other drugs that are currently in development, including a drug called selinexor, which is an XPO1 inhibitor that offers patients, even with penta-refractory disease, responses that are approaching about 20 to 25% as a single agent. So I think that this is certainly a disease where there is a lot of optimism about treatments in development, and outcomes for patients will improve even further.